So we've covered some neoplasms of the adrenal cortex. The next two are going to be important tumors of the adrenal medulla. Neuroblastomas, which we'll start off with, are almost exclusively pediatric tumors. Now, what does the root blast tell you? They're immature cells, much more so than the next tumor you're going to see. And that means that they don't do a great job of hypersecreting the normal products of the adrenal medulla. What does it secrete again? Epinephrine and norepinephrine. So, if you were expecting to see a jittery kid who looked like he got stabbed with an EpiPen, that's usually not the case. They usually don't even have hypertension. In fact, the most common presentation is actually just a huge abdominal mass that's irregular and capable of crossing the midline. Also, being blast cells, their histology looks sort of like this. Those cells that look undifferentiated and mostly like big nuclei. Last fun fact, while these tumors are most commonly found in the adrenal medulla, and are almost always found in the abdomen, they can actually be found anywhere up the sympathetic chain. Crazy, right? You actually have these in your neck or near your spinal cord. It's not really a high-yield fact, but kind of a cool point. Now, as is the case with a lot of the cancers on this test, the stupid trivia actually does matter. The most frustrating questions on this test, by far, the ones that make you go, did they really just ask that? Have got to be the cancer questions. They ask you to regurgitate some stupid tumor marker or oncogene that you thought, hey, that's never going to be on the test. But they come up. They're not the highest yield things, but if you don't study them, just because they're not fun to memorize, you'll be missing out on a fair number of points. So, now that we've gotten my rant out of the way, here are some factoids on neuroblastomas that you should definitely make flashcards of. First of all, while there usually aren't enough catecholamines to be highly symptomatic, there are usually enough to where you find catecholamine metabolites, otherwise known as metanephrines, in the urine. This isn't sensitive enough to use as a rule-out. Remember, these immature cells aren't actually very good at synthesizing catecholamines. The other markers that you should know about are bombesin and neuron-specific enzyme, which makes sense because the adrenal medulla is practically a sympathetic ganglion anyway. You can supposedly see Homer Wright rosettes on a slide, but I would honestly just know the name. I've never been able to see him. And finally, the most important predisposing factor to remember is that neuroblastomas are associated with the presence of the N-MYC oncogene. Now, a neuroblastoma is one of two common types of abdominal mass found in kids. The other is called a Wilms tumor, a type of tumor that originates from renal tissue. And while a CT is the best way to differentiate between the two, there's a couple of good ways to tell them apart in a vignette. First of all, while both are pediatric tumors, kids tend to get Wilms tumors a bit later in life than neuroblastomas. Next, Wilms tumors tend to be smooth to the touch and never cross the midline of the abdomen. You will almost certainly see a description of one of these masses to palpation on your test, so I would definitely know the key difference between how they feel. Neuroblastomas are irregular and can cross the midline. Wilms tumors are smooth and never cross the midline. For more information, you can check out the renal section, but these are the most important highlights on the differential. Pheochromocytomas, or PHEOs, as we cool kids call them, are probably the higher yield tumor of the two. And really, they don't actually have a ton in common with the neuroblastomas, besides the fact that they're both adrenal medulla tumors. But unlike neuroblastomas, these are usually pretty well differentiated cells, and are actually very good at secreting catecholamines. Now these tumors tend to secrete catecholamines in bursts, so they end up causing short episodes of sympathetic arousal. Now what kinds of symptoms would you expect a catecholamine surge to cause? So a massive release of norepinephrine could cause your cookie cutter palpitations, perspiration, pallor, but this is all pretty vanilla, right? I mean, everything from hypoglycemia to an MI to even a panic attack can cause all these. What really distinguishes PHEOs is the insane amount of hypertension they cause. Seriously, it's like in the 200s over 100s. Because not only does the beta-adrenergic activity push the heart to maximize its cardiac output, but the alpha-adrenergic activity causes systemic vasoconstriction that cranks the blood pressure up by Ohm's law. That's physics. Now this leads to the complaint that brings most patients in, severe headaches that co-occur with these episodes. The other major finding that helps you identify a PHEO is what breakdown product in the urine. Again, it's the metanephrines, homovanillic and vanillyl mandelic acid, along with the catecholamines. Burn those names into your head because they're major buzzwords for PHEOs and neuroblastomas. Now, HVA and MVA are actually sensitive and specific for PHEOs, unlike neuroblastomas. So how are we going to deal with this tumor? To quote the old surgical adage, when in doubt, cut it out. But hold on a moment. These tumors are actually very touch sensitive. If you even look at them the wrong way, they could flood your system with catecholamines and send you into a hypertensive crisis. So how can you medically prevent that from happening? By using pharmacologic blockade of the adrenergic receptors before you operate. A strong enough combination of alpha blockers and beta blockers, such as phenoxybenzamine and propranolol, should do the trick. Now here's the money question. Which one do you give first? If you said beta blocker, congratulations! You just killed your patient. I'm messing with you. But seriously, don't do that. See, an excess of alpha-1 activity is keeping most of the arterioles in the body at a high level of resistance. But the beta-2 activity is keeping a small but sizable portion of the peripheral vessels, to the muscles for example, wide open. So what do you think happens if you're already hypertensive and you beta block the patient? Now once you beta block the patient, there is nothing stopping all of those alphas from slamming every vessel in your body shut, making a hypertensive crisis way more likely. So what you actually do is you start out with an alpha blocker to stop the global vasoconstriction. That way, when it comes time to start the beta blockers, you can slow the heart down without worrying that your peripheral blood vessels are all going to slam shut. After you've done that, then you can do your adrenalectomy. Finally, I'm going to wrap up with epidemiology, which is a pretty important section for PHIOs. First of all, PHIOs pop up in a large number of tumor syndromes. These include, as you may remember from the neurology section, the neurocutaneous disorders, von Hippel-Lindau, and neurofibromatosis type 1. They're also extremely prevalent in the multiple endocrine neoplasias, or MEN syndromes, which we'll be talking a lot more about later. One interesting thing to note is that all these symptoms that tend to involve PHIOs are autosomal dominant. The famously cited rule of tens applies to the epidemiology of pheochromocytomas. 10% of patients with PHIOs have extraadrenal tumors, meaning that it's possible but not as common as in neuroblastomas. 10% of the patients have calcifications that they can see on CT. Malignancy, bilateral disease, and pediatric disease also run at about 10%, but it's worth mentioning that in patients with familial tumor syndromes, these actually end up being a lot more common. Alright folks, let's wrap this section up on adrenal medulla tumors with a test of your knowledge. It's time for a flash quiz. High yield fact time. What's the name of this class of metabolites found in the urine of PHIO patients, and what are the specific names of two of those metabolites? I know those names are long, so pause and take some time to think about it if you need to. The name of the class of metabolites is the metanephrines, and the names of the specific breakdown products are homovanillic and vanillyl mandelic acid. You'll often see them abbreviated as HVA and VMA. Just remember that they both have vanilla in them. Remember, you will always see these in PHIO patients, but you'll usually see them in neuroblastoma patients.